All right, today we're jumping into one of the most intense and, frankly, confusing syndromes in all of critical care: disseminated intravascular coagulation, or DIC. It's this wild situation where the body's clotting system just goes haywire, and you get this bizarre paradox: clotting and bleeding happening at the exact same time. So let's unravel this thing together. So here's how we're going to break it down. First, we'll tackle that paradox head on. Then we'll peek under the hood and see what's causing the system to go into overdrive. After that, we'll get into how doctors actually diagnose this chaos, and then, of course, how they try to manage the crisis. And we'll wrap it all up with the core takeaways you absolutely need to know. Okay, so let's dive right into the heart of the matter, the central puzzle that makes DIC so incredibly perplexing and, well, dangerous. I mean, this is the question, right? It just seems to defy logic. The very system that's designed to stop bleeding, coagulation, suddenly becomes the cause of it. To really get our heads around how this is even possible, we need to start with a solid definition. Okay, I know that sounds like a textbook, but a couple of words in there are absolutely crucial. First, acquired syndrome. This is huge. DIC isn't a disease you just catch. It's always a complication, a catastrophic response to something else going terribly wrong in the body. The other key phrase is systemic activation. This means it's happening everywhere at once, not just one little spot. So what could possibly set off such a runaway train? Well, the triggers are basically a who's who of medical emergencies. We're talking massive body-wide insults like severe sepsis, major trauma, widespread cancer, or life-threatening obstetric problems. It's these huge events that flip the switch and push the body's normally life-saving clotting system into a complete and utter overdrive. So, we have our trigger. But how does that actually flip the switch? Now, we get to the really interesting part, the core mechanism. Let's see how one big problem unleashes this absolute cascade of chaos. And here it is, a devastating domino effect in 4 steps. It all starts with that trigger, which just floods the body with signals to start clotting. That kicks off step 2, a massive, uncontrolled explosion of thrombin. Then, in step 3, all that thrombin starts creating thousands of tiny little clots that gum up small blood vessels, basically starving organs of oxygen. And this leads to the final cruel twist in step 4. The body has used up all of its platelets and clotting factors to make these useless little clots. The supply cabinet is completely bare. So now, when a real bleed happens, there's nothing left in the tank to stop it. And that's the paradox right there. The out-of-control clotting consumes the very things you need to stop bleeding. Now, what's fascinating is that not all DIC looks the same. It can show up in 2 main ways, what we call phenotypes. And it all depends on the balance between clotting and clot busting. With the thrombotic phenotype, which you often see in sepsis, clotting is the dominant problem. The real danger is organ failure from all those microclots. But with the fibrinolytic phenotype, common in trauma or certain leukemias, the system that breaks down clots also goes into overdrive. And that leads to just catastrophic, life-threatening bleeding. So with that really chaotic picture in mind, how in the world do you diagnose it? Well, it's a puzzle, and you've got to look at the patient, the labs, and the whole clinical picture to put the pieces together. The signs you see at the bedside can be just dramatic and devastating. What you're looking at here is purpura fulminans. That's a really severe sign of the thrombotic side of DIC. It's what happens when all that clotting in tiny vessels cuts off blood supply and the tissue starts to die. But at the exact same time, this same patient could be oozing blood from every IV site. It's just a stark visual reminder of the damage this syndrome can wreak. And you know what? The lab results tell the exact same story. A story of consumption. The platelet count is low because they're all being used up in those tiny clots. The PT and APT, which measure how long it takes to clot, are really high, meaning it's taking forever to clot because the clotting factors are all gone. Then you have the D-dimer, which is basically evidence of clot breakdown, and it's sky high because the body is just desperately trying to bust up this mess. And finally, fibrinogen, the raw material for clots, it's in the basement because it's been totally exhausted. Every test points to the same disaster. To try and bring some order to all this chaos, clinicians use scoring systems, like this one from the ISTH. You can think of it like a checklist. It forces you to be systematic. You combine that essential clinical context, is there a known trigger, with all those key lab values we just talked about. It's a way to turn this chaotic story into a clear, objective number. And the magic number is 5. If you get a score of 5 or more, it's highly suggestive of DIC. It gives clinicians a really clear, standardized threshold to hang their hat on and confirm the diagnosis. You can even find clues under the microscope. See these? These are schistocytes. They're fragmented red blood cells. Just think of them as collateral damage. They're formed when red blood cells get literally ripped apart, trying to squeeze past all those tiny fibrin clots in the small vessels. It's a visual of the mechanical damage happening inside. But like the caption says, it's not a slam dunk sign all on its own. All right, so now that we know how to spot DIC, let's get to the most important part. How do we actually manage this life-threatening emergency? If you only remember one single thing about managing DIC, make it this. You have to treat the underlying cause. You cannot fix the chaos downstream if you don't shut off the trigger upstream. If it's sepsis, you hammer it with antibiotics. If it's trauma, you stop the bleeding. If you don't turn off that initial fire, the DIC cascade will just keep on burning, no matter what else you do. Now, while you're attacking the cause, you also have to provide supportive care, and that really falls into two main camps. First, there's replacement therapy. It makes perfect sense, right? The patient is bleeding because they've run out of clotting stuff, so you give it back to them. The other side of the coin is inhibitory therapy, where you're actually trying to slow down that out-of-control clotting machine, usually with anticoagulants. And a super important point here is that we don't just transfuse to make the lab numbers look pretty. The decision is almost always based on the clinical situation. As you can see, we're giving platelets if the patient is actively bleeding and their count is below 50,000. We give fresh frozen plasma, which has all the clotting factors, for active bleeding when those clotting times are getting really long. And if the fibrinogen level is still dangerously low, we give a concentrated source like cryoprecipitate. Now, I know what you're thinking. Using anticoagulants in a patient who might be bleeding sounds completely backwards, and you're right to think that. It takes really careful judgment. Full-dose therapeutic heparin is pretty much reserved for patients where clotting is clearly the biggest, most immediate problem, like if they're about to lose a limb. But here's the interesting part. Almost all critically ill DIC patients who aren't actively bleeding will get a low, prophylactic dose of heparin to prevent new, dangerous clots from forming in their veins. Okay, we have covered a ton of ground, so let's wrap this up by boiling it all down to the most important must-know points about DIC. So here it is, the bottom line. DIC, at its heart, is that paradox of systemic clotting and bleeding, and it's always set off by another major illness. The core engine is simple but brutal: runaway coagulation that burns through all of your resources. To diagnose it, you have to be a detective, using the clinical context, a panel of labs, and a scoring system. And, most importantly, the number one rule, the cornerstone of management, is to attack the underlying cause. And that really brings us to our final thought. It's a way of thinking that completely reframes how you should approach this whole devastating syndrome. If DIC is always a secondary problem, then this is the real question. Yeah, identifying DIC is important, but figuring out and treating the why, the sepsis, the trauma, the cancer, that's the only way you're ever going to resolve the crisis. It's a powerful reminder to always look past the dramatic symptoms to find and to fight the real enemy.